Hi, my name is Todd Driver. I'm a UCSF medical student, and on behalf of my mentor, Dr. Mike Schlipback, and his collaborators, I'm excited to present you my project, which is titled Creatinine versus Cystatin C in Detecting All-Cause Mortality Risk and Kidney Disease within HIV-infected women. And this is conducted within the Women's HIV or Interagency HIV Study, or WISE. As a brief background, as survival of HIV infection has improved, chronic kidney disease has emerged as an increasingly prevalent comorbidity, and detecting the presence of chronic kidney disease is important in HIV-positive populations because it is associated with increased mortality risk and can potentially impact treatment choice, such as the use of tenofovir. So the current clinical standard of detecting CKD by serum creatinine-based GFR is influenced by muscle mass, which can impact the diagnosis of CKD. So serum cystatin C has emerged as a viable alternative marker of kidney function and is not influenced by muscle mass. So while previous studies have indicated that cystatin C may be superior to creatinine for detecting CKD and mortality risk in HIV-infected patients, it has not been well studied in multiple high-risk populations, including women with HIV. Therefore, we designed this study within the Women's Interagency HIV Study to evaluate the clinical significance of differential GFR estimates based on creatinine and cystatin C, and the characteristics associated with these differences in the setting of HIV infection. In order to do this, within the Women's Interagency HIV Study, we studied 908 HIV-infected women and compared them to 289 HIV-uninfected women and measured serum concentrations of creatinine and cystatin C from stored samples from their baseline exam, which occurred from 1999 to 2000. And in order to evaluate the clinical significance of these GFR estimates, we used multivariate Cox proportional hazards regression to evaluate the associations of creatinine and cystatin C-based GFR with all-cause mortality, and to evaluate the predictors associated with different GFR estimates based on creatinine and cystatin C, we use multivariate linear regression. So this brings me to our results. So if you look at this figure right here, you can see the probability of mortality on the y-axis, and baseline GFR by cystatin C on the x-axis in this graph. And you can see baseline GFR by creatinine on the x-axis in this graph. And you can see that over the entire range of GFR, cystatin C is associated with a more strong and linear association with all-cause mortality compared to creatinine GFR, which is flat except at the lower GFR ranges. When we evaluated the associations of GFR categories with all-cause mortality, we found that within the lowest GFR category, below 60, both creatinine and cystatin C were associated with an increased adjusted risk of all-cause mortality. However, cystatin C detected a higher number of patients with an increased mortality risk compared to creatinine. And then when we looked at the slightly higher GFR range of 60 to 90, creatinine was no longer significantly associated with all-cause mortality, whereas cystatin C was significantly associated with an increased mortality risk. So the next thing we wanted to do was look at predictors associated with differential GFR estimates based on cystatin C and creatinine. And so when we looked at this, we found that demographic factors such as black race were associated with a lower cystatin C GFR estimate compared to creatinine. Cardiovascular disease risk factors such as being a smoker or having an elevated systolic blood pressure were also associated with a lower cystatin C GFR compared to creatinine GFR. And then having more poorly controlled HIV, such as a low CD4 count, a higher HIV viral load, and hepatitis C virus infection were associated with having a lower cystatin C-based GFR compared to creatinine GFR. So these results, when you look at all the unifying factors behind these predictors of differential GFR estimates, all these predictors are kidney disease risk factors. And so these results suggest that those at the highest risk of kidney disease are also at the highest risk of having a creatinine GFR misclassify HIV-infected women according to CKD status and mortality risk relative to cystatin GFR. So in conclusion, among HIV-infected women, cystatin C-based GFR detects kidney dysfunction and all-cause mortality risk that are missed by creatinine-based GFR, particularly amongst patients who are at the highest risk of kidney disease. So these results suggest that cystatin C is a better measure of kidney function than creatinine in HIV-infected women.